Hi, everyone, and welcome to today's webinar. I'm Erica Carbajal with Becker's Healthcare. We're going to be discussing breaking the status quo, how AI can drive change within health systems and staffing amid staffing crises. And this is sponsored by CoreT. Before we start off, I have just a few quick notes on the back end, on our side, some housekeeping instructions. So the session is being recorded, so it will be available after the event. So if you want to go back to reference anything, you can go ahead and use the same login information that you use to access today's webinar to access that recording once it's available. You can also submit any questions you might have by typing them into the Q&A box that you should see on the right side of your screen. And if you're having any trouble with audio or video, please just try refreshing your browser or submitting any technical questions into the back end. With that, I'm pleased to be joined here by 4 hospital and health system leaders, as well as Andreas Cleve of CoreT. To start us off, I'd love to give each of our speakers just a moment to briefly introduce themselves and share a bit more about their organization. So, Andreas, can you kick us off here?
Yes, thanks for having us. My name is Andreas Cleve, and I'm the CEO and co-founder of CoreT. We're a 100-people AI team building tools for payers and providers. And our core product is an AI co-pilot that listens in during patient interactions and helps to write notes. It codes, it quality assures, and it helps to nudge on questioning to ensure everybody gets the kind of care they need. We're originally founded in Copenhagen. The majority of our work is happening in the US, and we're excited to dive deeper into this conversation about AI and how we best can deploy it in healthcare.
Welcome. Dr. Barkuda?
Thank you, Erica. Abram Barkuda from Bay State Health. I'm in the role of System Chief of Hospital Medicine and Regional Chief Medical Officer and Chief Quality Officer. Bay State Health is not-for-profit integrated healthcare system in Western Massachusetts, headquartered in Springfield, Massachusetts. We have 5 hospitals, over 80 medical practices. We serve closer to 1 million patients in Western Mass. Thank you for having me.
Thanks for being here. Dr. James?
Hello, thanks for having me today. I'm Scott James. I'm Associate Chief Nursing Officer at Thomas Jefferson University Hospitals, based in Philadelphia. We serve as the academic medical hub and flagship medical center for Jefferson Health, 17 hospital systems spread across Pennsylvania and New Jersey.
Dr. Jang?
Thank you for the opportunity today to talk with you guys. My name is Navneet Dang. I'm an internal medicine physician with over 20 years of experience in healthcare. Currently, I have been part of Geisinger Health for approximately 8 years, and I am practicing internal medicine physician at Geisinger Community Medical Center in Scranton. I have been in various leadership positions within Geisinger, most recently as System Chief Quality Officer and System Chair of Inpatient Medicine. In these capacities, I played a pivotal role in leading various initiatives around improving quality, safety, and patient experience across the clinical enterprise. Currently, I am in the role of Chief Medical Officer at Geisinger Community Medical Center in Scranton, Pennsylvania. A little bit about Geisinger Health. We are an integrated healthcare delivery model of care and close to $6 billion clinical enterprise. We also have Geisinger Health Plan, and we take pride in taking care of our patients and communities through the whole continuum of care. As a health system, our vision is making better health easier for our patients, and we have 3 key strategic objectives which we work towards: managing total health, operational excellence, and access and ease of use. Glad to be here.
Thanks so much, Dr. Dang. And Joya?
Hi, Thank you for inviting me to join the panel with these fine colleagues. And my name is Joya Henderson. I currently serve as the Chief Nursing Officer and Nurse Executive for Antelope Valley Medical Center. It's a standalone hospital in the northern portion of Los Angeles County in California. And it strives to be the answer to Antelope Valley community. And I'm privileged to have been selected to co-lead this team with my CEO, Ed Mirzabegian, who's, I want to say, world-renowned executive. He's been in his role as a CEO for quite a while, and I'm being mentored by him. And so it's a great honor and privilege to work side by side with him, along with leading our team to excellence. And so our dynamics are quite unique. It's kind of like a mixture of rural, state, county. I mean, it's just like a plethora of things, but it's nonprofit. Our ER, I want to say, it toggles between LA County and us as being the busiest in the county. And we see at least over 400 patients a day, especially now with the tridemic upon us. We have RSV, COVID, and flu. So we're definitely seeing peaks in that. And so a lot of times we're the 8th busiest ED in the nation with trauma level 2 as well. So we're the catchment area of about 1,500 square miles. So it's a huge area that we cover in LA County to rescue the community. And we're also a comprehensive and thrombectomy capable hospital. We have STEMI. We're bringing on transplant services. Our CEO has developed that program, and so I'm fortunate to co-lead that with him. And so the goal is next spring. And so really we do it all. We're really striving to be the answer to Antelope Valley and really the Los Angeles County community as well. So our demographics are interesting because we have about 35 to 40% of our patients we see are Medi-Cal. So we're challenged with that, with providing the needs where a lot of times the emergency room is where they're getting their primary care. So tasking our staff then and our physicians to be attuned to that and making sure we're delivering and providing care and instructions that they can follow and understand once they get back into the community. So we have a nice amount of challenges set before us, but we are poised and we're ready to meet those and exceed those for our community that we serve. So again, thank you for having me, and I look forward to our discussion.
We're so excited to have each of you. Truly appreciate all of your time. We've got such a wide range of backgrounds and geographic footprints here, so it should make for a really dynamic and strong discussion. I want to start, obviously, we continue to see and know all the headlines and anecdotal reports and data, burnout, stress, low satisfaction continue to afflict the healthcare workforce. So can you start there and speak a bit to how you're seeing these issues play out within your hospitals and health systems and what your biggest challenges or concerns are there? Joya, I know you mentioned the triple-demic and sort of pressures there. So let me start with you here.
Yes. Interesting question. So thank you for that. I did ponder on this, and what we're seeing are, of course, everyone is feeling this, the burnout. We're seeing that. We saw that in the topics here in the Becker's convention as we talk to our colleagues, and it's in every industry, not just in healthcare, but especially healthcare, right? Because we never stopped and we're still going. So it's like a marathon. So we're trying to pace ourselves. So burnout is really a top of mind. Also, sick calls. We're experiencing quite a amount of sick calls. I know now it's, coupled with the tridemic that we're seeing, our colleagues are actually physically sick, and also there's a touch of, I want to say, maybe apathy, because it's like a numbness that you'll start to see in different ones. And so it's just really trying to put your arms around people figuratively and as well as physically if needed, to have those safe spaces so that you can have that conversation to recharge and to be well for not only yourself, but for those that we serve.
Dr. Barkuda, I saw some head nods from you as Joya was mentioning sort of the numbness. So I want to turn to you. How are you seeing burnout and stress continue to show up in the workforce today?
Thanks, Erica. I would like to just build on what Dr. Henderson just shared. We work closely, of course, with the CNOs and the CNEs across the country. And maybe we can zoom out a little bit and just look at the big picture. I think we're encountering the 3 Ps, the patients, the providers, and the profession. And I'm going to zoom on healthcare right away, where we know our patients, the census showing that getting older, more complex, the care delivery that our patient will need, especially within acute hospitals, will require more complex disease management. And we keep our eyes on length of stay, but that really taken the cachet we have from the workforce and labor. The second P is really the provider, the frontline provider, the nursing, doctors, clinicians, APPs. We know that the burnout is real. I would like just to maybe put one data point, the Medscape report, 44% of physicians in the US, they're saying we're burnt out, we will find something else. So this is 1 out of 2, major. The third part is the profession. We need more doctors. We definitely need more nursing. We've seen the agencies that chimed in to help with staffing. Is that enough? We know we need more. We need better nursing ratio for staffing for the inpatient. We need more forces at the front line. We need an upscale, to say the least, in medical schools. We need a better pipeline that take the nurse practitioners and the physician assistants and get them through the healthcare in a way that we could use these forces. I think it's always going to be multifaceted, but we need to make sure all these factors and what would be modifiable, short, medium, long term, and how we can curb it. Apathy, I could relate to what we've been suffering post-COVID, and that's mostly on the provider strain, on the workforces, and also the system.
Yeah, absolutely. Definitely echoes what we continue to hear and see around really healthcare just having to do more with less for the foreseeable future. Dr. James, let me call on you here to talk a bit about how this is playing out among Jefferson Health.
Well, so Jefferson Health and Thomas Jefferson University Hospital in particular, we're located in downtown Philadelphia, as I stated earlier. So we are seeing an increase in violent crime and violence against healthcare workers. We recently implemented a weapons detection system in our hospitals that we're slowly working throughout the system. And this has given a little bit of relief to our staff, but they are still, victims of violence almost every day when we get these reports. So it just adds to that mental breakdown at the end of the shift when you're trying to hand off to the next nurse, and you're talking about the patient information and the patient handoff, but also what is the handoff from caregiver to caregiver as well, as far as how you're feeling and how are you going to make it through the shift. So we're doing our best in supporting those individuals, physically through the weapons detection system, et cetera, and having more security guards, things of that sort, but also on the back end, where do they get that psychological support? So we put some new programs into place to support them along that way. We see the same thing. We see absenteeism going up. We see nurses coming in the first 90 days, they're ready to get out of the unit that they came into and move to a non-bedside unit to go to an outpatient clinic. And a lot of the mental anguish we hear is just from our preceptors. There are so many new grads and so many people to mentor. How do you find the strength day in, day out to take care of patients and then also precept a new grad? It's a good thing, but there is a cost that is associated with that.
Absolutely. And last but not least, Dr. Dang, we're going to turn to you to weigh in here as well.
Yeah, no, thank you. This is such a great question, and I think a lot has been already covered by my esteemed colleagues. I was going to mention the recent Medscape survey that Dr. Barracuda, mentioned, And I really liked his approach, 3 Ps. I think that's really great. So a couple things about clinician burnout. I feel burnout was present prior to COVID, but COVID has significantly accelerated it. And, we are not unique. We are seeing clinician burnout in our wider footprint across Geisinger Health System as well. One of the things that as a system, our system has really taken a neat approach to attack clinician burnout. Our chief wellness officer has really developed a lot of tools to support our employees and also our clinicians to mitigate burnout. And there have been a lot of surveys that were done pre-interventions to understand the scale of burnout with all our employees. And there have been some targeted interventions based on the feedback that was collected on some of those surveys, which are specifically for wellness. I personally took that survey, and I felt like that survey was very helpful to understand the scale and magnitude of burnout within our health system. So there have been a lot of work, as I mentioned. One of the common themes that we identified was around a lot of administrative burden on clinicians. And a team at Geisinger Health has worked towards Epic in-basket management, and they have really done some nice work that how do we decrease that administrative burden on our clinicians. So I think that's just one example how multidisciplinary team has worked to mitigate and decrease administrative burden on our clinicians. And there are a lot of other resources that have been developed as well. One of our stroke neurologists, he's very passionate about clinician burnout, and he has done some studies around one-on-one coaching, and a lot of that literature is already published by him. But there is, in nutshell, I would say that there has been a strong focus and a lot of good work done as a part of our health system to mitigate burnout in our employees and our clinicians.
Yeah, thank you all so much for sharing all of that. I think it really underscores what we hear so many leaders say around not being able to recruit our way out of the labor shortage and just having this be such a multifaceted issue that really involves support in a number of different ways. Dr. James, you mentioned the physical security aspect, administrative, of course. Andreas, is there anything else you would add here based on your bird's eye level perspective?
Fascinating intro, and thank you all for sharing. To stick with Dr. Barkuta's 3 Ps, which I really like too. I am a patient. I'm not a professional. And I ended up running my now second healthcare technology company because healthcare ultimately shaped my life. My mom was in psychiatry, got attacked by a patient, and ended up in cerebral rehabilitation for the best part of my childhood. And doctors and experts and nurses saved my mom and gave her back to the family, and their help sort of shaped my entire life. My much smarter sister became a doctor, and I'm ultimately here trying to build technology. And I think just building a little bit on this and being a technology nerd, so forgive me, I can't help but feel sort of some of the adversarialism that is created, the apathy, the problems we have here also is something we're facing with AI. And I'd love your opinion on this, but ever since I started touring the world and seeing healthcare systems across the globe, I've met a lot of people saying, oh, AI. And I think AI has a little bit of that flavor of adversarialism. It's coming to take our jobs. It's another sort of threat outside in. And I can't help but feel that we as vendors also have been terribly bad at making it meaningful, being about these issues and not just yet another Silicon Valley savior complex coming in and trying to transform healthcare. I think that's not the goal. That's not what I've experienced. And I think we haven't been good enough at addressing the problems. But I also see that some here in this room and beyond, a lot of healthcare professionals, nurses, and doctors are really trying to see now how they can take ownership of this technology narrative and the AI narrative and see how it can be helpful. So I'm really hopeful that AI can play a role in reshaping some of these underlying problems, and we're at least seeing that. But would love to hear your opinion on sort of how AI sort of is sort of impacting the current stress and mental issues at work.
I will take that. I wish, so Andreas, thanks for sharing, and we all collectively share some elements of your story and many others that we have about the system, about the patient, about our interaction. Maybe just to build on your question and bring it back to Dr. Dang comments that in AI, if you take, I'm gonna keep on the roll with my acronym. So A should be for automation, which is the fear that, are they going to take my job? This is something that's going to change the landscape? And the answer is, historically, we've seen the automation entering and the workforce been at least redistributed, redeployed. We lived that, and this is now the next phase where we really need it. This is not the innovation catching up. Healthcare needs better tools to know how we manage the population at large, and then go down and have that precision medicine, which is AI is leading. So this is the A, automation. The I that I want to focus on is the implementation, right? So the culture really could eat anyone's lunch, but just to take it to what we're going to do with this. This is, the AI is not just a generative AI. We need AI to improve detection, to manage what we do in health system, to automate specific function that we could do better with that. And I'm just going to throw this: prior authorization, administrative tasks. So this is all coming into that implementation part. Just kind of more bring it together that there is a culture it's going to be resistant to change. But then we have the tools, how we can deploy, how we could do what we do better, and have that patient we're thinking about in every case. And I'm privileged that I still see patients where you have that centric case, the patient, how we could deploy the value-based services for an N of one and then take it to the population level.
Yeah, thanks, Dr. Barcuda. I think you raised an interesting point around the culture aspect and just focusing on how do we improve, how do we do better, and how do we ensure that our culture is not going to be resistant to change. So I guess as building off that, Joy, I think you had your hand up, so I'm not sure if you wanted to chime in.
Oh, thank you, Erica.
Yeah, to talk
Yeah, I echo Barracuda, Dr. Barracuda, some of your thoughts, and and a little bit more to Andres. Thank you for opening the door on that conversation. You're right, that is a concern. You know, there is that trepidation about it, and how do we, marry the two, meaning the front line and us wanting to be innovative and leveraging technology, right, to complement our work. And so I say through transparency. And also, and I think you were leaning in this direction, is also shifting the message so that it doesn't feel off-putting to the end receiver, so that they can understand that this is not to take their job. This is to help complement them. This is to help them do their job better, less stressful, and be better in the moment, to those that they're serving, as well as their colleagues and hopefully their family. So hopefully it has a, multi-layered effect and positive for us. And I also challenge that when we decide to do something new or different, come up with something new, a pilot or what have you, my secret sauce has always been to include those that it impacts around the table, in the planning, in the initial ground stage of developing the change. Because then you get the buy-in, you get their pushback is aired out, they feel heard, and they're valued because they were around the table to help us plan this initiative. So that's something I'm looking forward to doing. I do have a a challenging, I think we all might experience this, where you have different generations that you're working with. And so, which I love, because then you are able to glean from everybody and everything. And so I love diversity in so many ways, but having that, it's interesting because then you had different mindsets in the room that you're listening to, but you want to incorporate, but you want to make sure that those contributions are moving us forward at the same time. So it's really a dynamic there that, I find challenging, but I quite enjoy at the same time. So I'm looking forward to implementing AI to complement in the patient care setting with helping with admissions and discharges, and really helping to decrease the load off of the frontline nurses and also with the physicians, managing their messages and how we communicate to them and streamlining things so that we're not overburdening and overtaxing them. And actually, we're thinking through the process with them. So we're complementing medicine at the same time.
Yeah, Joy, I think a lot of what you said goes back to what you mentioned at first around transparency and involving the end user and the clinicians in the process, having diverse mindsets in the room to weigh in real time as changes are happening. Dr. Dang, is there anything you would add here in terms of how AI technology is being used to address some of the key concerns we opened with?
Yeah, no, I think this was great conversation, and I loved what Joya said, that AI is, I think the message for our frontline teams has to be that we are leveraging technology to enhance their workflows, and to make the workflow easier. And I don't really feel that AI is going to take away anybody's jobs, but I feel like this is going to enhance enhance the workflows. So, couple examples I feel where we can really leverage precision medicine and AI. I mean, I think one of the unique areas is colon cancer screening, right? And if we are able to leverage AI and really outpick some of those patients which are going to benefit from colon cancer screening in the short term, we can save a lot of lives doing that, right? With early colon cancer screening. I think that's just one example. One area where, as a health system, we have leveraged AI in some fashion is in the outpatient space. That how do we pick patients who have congestive heart failure or type 2 diabetes or CKD, especially in the chronic disease management phase, and worked on care gap closures so that we can really optimize outcomes, patient outcomes regarding mortality, readmissions, and some of the other adverse events that can happen if you are not paying attention to managing these chronic diseases well. So I think that's one area that we have really leveraged AI, but there is more room to do even better with the current technology. So those would be my thoughts.
Thanks for sharing those examples, Dr. Dang. I'm going to move on to the next question, just in the interest of time here. But Dr. James, let me start with you. Can you speak to how you've applied technology across Jefferson Health to patient-facing roles and then tasks on the back end? So how, if at all, those approaches might differ?
Sure. So very interesting question, and certainly applicable even now, before we're like Jefferson Health is just on probably the beginning of implementing AI, but we've done a lot in the way of machine learning and deep learning. So, for instance, we've already started predictive modeling for sepsis. That's a huge initiative for us just this past year. That has been implemented. We're seeing great reductions in sepsis mortality as a result of that. Our deterioration index for patients has been amplified by using AI as well. So patients don't necessarily have the rapid responses or some of those codes that we've seen in the past, because our teams are alerted to things going on beforehand. We've used CT and imaging interpretation as well, has been amplified. We're getting ready to start a telesitting and telenursing program, which will truly be face-to-face with the patient, and we'll be able to take some of that workload off of our nurses. Our issue right now is, with behavioral health and substance abuse patients in the hospital, to maximize their safety, we use a lot of one-to-one sitters. We don't have a telesitting solution for that yet. So sometimes we're using 10, 12, 15 individuals to make that happen throughout our 600-bed hospital. So implementing this type of telenursing solution is going to be tremendous for us from a resource standpoint, and just from the standpoint of being able to collectively watch these patients, gather data on them, and make sure that we know in the future behaviors that might be indicative of harm, et cetera. So we're going to learn as much as we can from that as well. Of course, we're using this clinical decision support as well. That's already implemented. It's reducing our costs and preventing harm as well. And then lastly, one of our probably most exciting projects that I'm leading with a team is we're really looking at behaviors around early departure forecasting. And we're hoping to use some machine learning in that and some AI, in that we want a predictive model of patients that come into the hospital, their probability of leaving by elopement or AMA, or if they have some type of behavioral substance use disorder, where we can trigger early, get them the resources they need, prevent them from leaving, and continue their care while they're in the hospital. So we're really excited about that and what AI may help us with.
Yeah, some great examples, a lot happening for sure on the predictive modeling side. Dr. Barcuda, can you share a bit from your experience at Bay State Health in terms of examples of applying tech to patient facing roles as well as back-end operations?
Excellent. Thanks, Erica. So just to build on Dr. James's comments, that maybe we're still into the first phase, which is how we can implement more tools directly with that interaction with the patients. Telemedicine is the platform within AI driven. We know how to manage it, how we schedule appointments, how we could also do better in terms of tool specific modules that we do with the patients. So this is really more on the first P of the 3 Ps, which is the patient, how we can engage the patient with the AI, and from our end, how we can get the patients who really need to be seen, even screen your ED, screen your panel in the clinic, and bring that up based on a predictive modeling. The second part, which I love, the decision support that we have through any EHR now, and all these tools of, we know there will be patient at higher risk. How could we nudge behavior and make sure that the providers are more alert with the standardized AI? We had so far, I would say, mixed experience. The sepsis, we heard very positive cases. We had cases that we did not know how to fine tune that AI tool and integrate the human part of it. This is still within the provider to the patient. I would like just maybe to zoom out and just go to the big system level. So I think there's a lot been done in terms of the CMI augmentation with AI, in terms of documentation, in terms of billing, all these administrative work that we've done on the system level, the back end, the balcony of how we run the operation, that it really helping us to reduce that. What's been estimated by at least a couple of publications, that's 1/3 of the healthcare spending. So there is a financial opportunity, there is a human labor opportunity there. To take it a step further, in clinical operation, the AI platforms are adding layer of I would say value, to say the least. You wake up every day, you look at your hospital census, you see where your patient got discharges, where you have the augmentation, you look at length of stay. There are a lot of predictive modeling through multiple platforms that really helping you with this. And to manage that level, the high level of the system, to Dr. James's point, you also need to go down and make sure every patient is cared for. So the next part is how we can bring them together, how we could get everybody to have the same talk. We came a long way. I do remember as a clinician when the alert on your computer that you need to have a VTE prophylaxis. That is the early decision support. But now, how could you really understand that behavior with AI? It's not just a snapshot. Let's interact with it as a tool and gain more knowledge of how we can provide the care.
Yeah, interesting points around the phase we're sort of in healthcare and where we need to get to in terms of connecting all those 3 Ps and connecting all the dots. Joya, what else would you mention here in terms of any specific examples of how you've used tech in patient-facing roles as well as backend?
Yes, thank you, Erica. Just to add on to tag on to what doctors Barakuda and James have mentioned, we have used sitter, if you will, in certain areas. So that's an area that we've branched out into. But I do want to explore what Dr. James mentioned is that rescue piece there with the RRTs and really helping to support the nurse because the AI isn't going to replace that. You still will need that human interaction and assessment, but it will help complement and recognize things through its predictive, modeling. So, and that would be very helpful for, like we like to term them, our baby nurses. They're right out of nursing school, and so many of them, didn't have the adequate training and exposure, especially when they were going through training in COVID. And so now we're really impacted by that experience. And so it's really a win-win because it will help the patient to get the care that he or she needs sooner. And so those are an additional other things that I want to bring to my C-suite colleagues and get them to appreciate this and see the need in us investing in these different models so that it will help our patients as well as our staff, and it will help with the stress that they have to undergo day in and day out. We talked about as before the precepting and the new grads, and I mean it's just a lot of responsibility. And on top of that, our patients are sicker. They're much more sicker now. So with these comorbidities, and so you feel the stress of that responsibility that you have to take care of them. So definitely having that empathy for them. And so trying to persuade and convince my cohort as well. So it'll be fun.
Yeah, absolutely. Joya and Dr. James hear so much from nursing leaders around the challenges of trying to sort of beef up training for newer nurses who maybe didn't get that the same experience they would have otherwise during nursing school, and the opportunity for technology to sort of augment that process. Next year, I know we've kind of talked about already sort of the hesitation and tackling that, and then got into some of the specific uses around technology to address some of these challenges around burnout and administrative stress. So I want to talk about outcomes as well. So what patient, staff, and/or operational outcomes have you seen as a result of applying AI to workflows? Andreas, let me turn to you to start off on this one.
Thank you, and thank you all for sharing these great points. Hearing all this just gives me so much energy. I think nobody here believes this, but outside of healthcare, I sometimes hear at conferences and other places that people say stuff like, oh, healthcare isn't ready for AI or new innovation or technology. And I think it's just so not true. Think about like just how many devices and machines and technologies are in the hospital today already. And I think I can't be more excited about the future when people are thinking so critically about it. But I think to Joya's point, what we've seen a lot with AI and the lack of impact, I think it comes down to that majority of the AI built today hasn't been built to create excitement in the workflows for the actual users, the nurses, the doctors, the practitioners. And that ultimately made AI sort of a technology for the sake of the technology, not for the users. That, back to the point of implementation in the eye on AI, is just so key. And I think that sort of builds on my first point coming from our advantage, is that we have this delineation between back office and front office. And I think that's back to sort of the idea of replacement and sort of is AI here to take my job and all that stuff. To me, I think documentation is not the symptom of a disease that's wrong in healthcare. Documentation is a symptom of the ambition to keep on doing great work and scaling that across the systems. But I think we all agree that the majority of people today think that the administration and documentation burden may have taken too much of a toll at this point, and it's just reducing the enthusiasm, right? But I think that's like, we're a patient experience platform. We've built technology to sit in the room when a nurse or doctor is with a patient virtually or physically. And what we very much believe in is that if we actually get AI tools that is built on top of the best practices of that system, the AI can help scale those so the experience becomes better for the patient. And I think that's sort of the flywheel that starts to scale, because the moment you can nudge behaviors in an interaction, that will in turn mean better questions, which will mean hopefully the patient feels more seen, which in turn hopefully will lead to better documentation because you've asked all the most important questions, which in turn will lead to Dr. Barracuda's point on the financials. Now we can make the AI, after that great interaction, document more of it. It can write more journal notes, it can code. And all of a sudden, there is a different kind of need for a focus on documentation, but it's not removed or gone. It's still there. It's just augmented or improved because we had more focus on the actual user and what they were there to do, which is obviously not the paperwork. And that just gives me so much energy, because what we're discussing here is exactly this. How do we put the user front and center? And I think that's what we've seen now. We cover more than 30,000 patient interactions per day. We're on free continents. We help some of the biggest brands in healthcare have really great patient interactions. And what we see is that when we augment a nurse, which is a group we're super excited to help because we feel they need better tools, and they're doing a really important work that might, in some cases, be underappreciated. We can do a lot on just helping to nudge. We can scale best practices for new staff members who might be new to the best practices of the hospital or the provider, and now they get this helping hand so they don't feel alone in the room with a more sophisticated and often more sick patient, to Joy's point. We can make sure that they get the help to document, that they feel there's something more in the room, which isn't some foreign AI, but the AI built by the superiors on the standards they're using, which ultimately means that we're not just scaling random generative AI, we're building a per system, per provider AI system that builds on their best practices, which ultimately, I guess, is the IP of healthcare, is the experience and the care delivered. And I think that that's where we get really excited. And then finally, at the end of such a call, what we also see a lot in healthcare today is that there's a lack of feedback, right? Nobody has time to stop up and take that feedback session, that QA session, that QI session. And AI, again, can help make sure that after every interaction, there's actually feedback given. So we can see in our data that highly feedbacked members of staff might be feedbacked by an AI, but if they get feedback every day, we can radically increase the happiness at work, and we can reduce the burnout, because we can see that they actually feel appreciated more and more, and they can see why, back to the point of transparency, they're doing great work and where to focus. So I get very excited by this conversation, and I think we're going to see a lot of changes that's more on the premise of the user and not just the vendors.
Thanks, Andreas. I think you speak a lot to just the idea that a lot of these tasks are never going to go away, but can we augment them to the best of our ability and make them sort of not just get the best out of it and ensure that the work that's going into it is actually all valuable in terms of for both the provider and the patients. In terms of any other specific sort of examples of outcomes when applying AI in workflows, I just want to hear from a bit of our providers here as well. So Dr. Dang, let me turn to you first here.
Yeah, no, thank you, Erica. I mean, I loved some of the points that Andreas made about AI and how can you really improve patient outcomes. I can share a couple of examples where we have really leveraged technology and that has led to improved patient outcomes. Dr. James mentioned about sepsis alerts. And I can tell you that as a part of our EHR, which is Epic across the clinical enterprise, we have used sepsis alert system, which really nudges the clinical teams, the nursing, and the provider teams that this patient has a probability of sepsis. And that really takes them, if our providers accept that, then that really takes them to what we call as proven care order sets, which really include the best practices, which are evidence-based practices, how to manage a patient with the severe sepsis or septic shock, how much fluid needs to be given, what are the antibiotics that need to be given to take care of those patients, and how do we do a 3-hour lactic acid collections and blood draws that are needed. So that has really helped. That just the sepsis alert system has led to better bundle compliance for our sepsis patients. And we have seen improvements in our patient outcomes when it comes to sepsis mortality and sepsis readmission. So that is one example. The second example I would like to share, we have also utilized readmission risk score, which is another lever that our teams are able to identify patients even prior to discharge at the time of admission if they have high risk of readmission. And they are really able to identify what are some of the areas that they need to work on so that at the time of discharge, they are able to address some of those social determinants of health by our care management team is able to connect them with outpatient care management support to address some of those social determinants of health so that we can improve their risk of readmission. So I think that's another area. Dr. James also mentioned virtual nursing. Our chief nursing officer at Geisinger Community Medical Center in Scranton has started the virtual nursing program at the intake process, at the time of admission, and also at the time of discharge. And I can tell you that's a huge patient satisfier. And at the time of discharge, when our virtual nurses are able to go over discharge instructions and go over some of the new medications that the patient needs to take, we have seen significant improvement in our medication communication scores on HCAHPS data. So I think that's another neat example. We are also leveraging technology post-discharge by remote patient monitoring tools based on the need. Say we are discharging a congestive heart failure patient and they are going to need a weighing scale, right? So all those, or if a patient was admitted with COPD exacerbation and now they are going to need to monitor their oxygen levels post-discharge. So pulse oximetry tools are provided so that they can kind of really closely track all that. So I can go on and on, but there are a lot of areas where we have been able to leverage technology and improve patient outcomes.
Thanks, Dr. Dang. It's so great to hear about the outcomes, the patient outcome improvements with the sepsis alert system and the value of that readmission risk score you had mentioned. You had mentioned as well, Dr. James's comments around the sepsis using technology to identify those at high risk of sepsis as well. So I wanted to turn to you, Dr. James, for any other outcomes you'd highlight here.
Yeah, I would just, sepsis is that our team has just done phenomenal work. I mean, a 25% reduction in mortality. So that's about 700 lives saved over last year, just as a result of that. So just the capability that you can build into these systems is just phenomenal. And I think it was already mentioned, we are using some ambient note taking and on the physician side right now. That's about a third of the cost of scribes. We have used scribes in the past and it just didn't work out so well. And so we were happy to start the ambient notes for our physician team. I think that's a really cool concept for nursing, and I don't think nurses will know what to do. When you talk about taking people's jobs away, that's the first thing that they would say, well, I spend so much time documenting, what am I going to do now? Well, you're going to have FaceTime with your patient. So I think that's probably something we should work really hard on next for our nurses, to get them back to the bedside, to let them practice at their top of license, and not spending so much time documenting instead.
Dr. Barkuda, I saw some head nods from you, so I wanted, before we move on to the next question, give you a chance to weigh in here as well.
Perfect. Thanks, Erica. Maybe try to bring it all together between Dr. Dang and Dr. James, that maybe the big focus here with the AI integration would be value, access, and quality, right? So VAC, throw more acronym. So value, we need better outcomes with less cost, right? So outcomes divided by the cost, the value-based premise of how we could do better, less mortality in the hospital, hopefully zero, with less resources used. So that's very important. The second part is the access, the outreach, the penetration that we have in our community, the patients that we can reach out to early. Love the concept that Dr. Dang just put it in front of us. Hey, we can, before you come to the hospital, I would know that your venous pressure is going up with the remote monitoring, and can call you in to avoid that hospitalization. So this is more access, better access. Know who the patient needs to have an appointment tomorrow versus the patient that, given a predictive modeling, I can get to see you by the end of the week. Quality. The cue here is very important. Less adverse events in the hospitals, less VTE events, less CAUTI, less CLEPSI. So these are the outcomes that we also wanted our patient to avoid, and that predictive modeling and less focus on the administrative task and more value of how we can provide the clinical concept would really drive that more. So value, access, and quality.
Thanks, Dr. Barkuda. I think it's so helpful to hear your perspective and connecting those dots and pulling out that we've heard from some of the specific examples. I know, Dr. James, you mentioned the cost of scribes and how much you were able to reduce that using ambient note taking. So thank you all so much. Next year, I just want to get to if there's any examples of success or barriers you face that we haven't gotten to in our discussion yet. Joya, let me turn it to you.
No, I mean, I'm just taking it all in, listening to my colleagues, and I see that we're all trying to solve for the same thing, and it's across the world, if you will. And I just feel it's important that we remain, I would say, flexible, adaptable, agile in these times, because we have all survived a major life-changing event that none of us, no human has really seen, right? And ever, really? Can I say that? And we are all, I feel like it's like post-battle, right? And so we're just all around, and the aftermath is here. So it's really important that we stay centered and have our arms around each other, show that human kindness, as well as being thoughtful about the pieces and things that we need to change, because we need to change, because it's like our patients, as we've said over and over again, are sicker, and they're not getting any better, even despite our efforts. And so recognizing that, and then using the tools smartly to augment, to support our physicians, our nurses, all providers that lay hands on the patient, so that we make smarter choices that add value. And then I think even we have to challenge up above us in terms of the reimbursement pieces. I can speak for our demographics. We serve over 40% of our patients are Medi-Cal. So I want to say on average, what do they pay? Like, I think I've been told 8 cents on the dollar. So that's, can I say, not fair, by the government to make that decision. And so really, as I say, looking at things as you say, Dr. Barracuda, to scale it back, let's take a big picture look at things so that we're really providing smart, safe, effective care to Americans, period. So I want to challenge that aspect of things, but in doing so locally, we each can do as much as we can in our respective spaces to take care of our teams, their well-being, and that the decisions we make are thoughtful and smart so that it really will help and add value.
Absolutely. Thank you so much, Joya. Before we wrap up, I just want to make sure we get to hear from each of you on one of these last questions here, just around change management. So for other leaders who might be listening to this and thinking about using more technology or using new technology to relieve their staff of pressures around administrative tasks or other time-consuming parts of their work, what strategies, best practices, or single piece of advice would you offer, particularly around change management? Dr. Dang, can I start with you here?
Yeah, sure. I think that's a great question. I feel the first thing we have to do is explaining the why, and we don't always, do a good job at engaging our bedside teams, or I would say frontline clinicians, whether they are nurses or whether they are our providers or APPs. So engaging them before we bring any of these solutions into the mix, and also getting end user feedback. One of the things I can tell you that we have really leveraged technology a lot, and there are a lot of tools in Epic, like sepsis alerts, and we use readmission risk score. But one of the things that I hear very frequently from our frontline teams is alert fatigue, and I think we have to be really careful that we are not introducing too much to inundate our clinical teams. I think that's one thing. The other thing that really helps with change management is active listening, and also taking the feedback really seriously from our clinical teams, and then hone in on that feedback and see how can we improve some of these tools. Because I'll give you a couple of examples. We started a lot of work. I think Dr. Barkuda mentioned about reducing hospital-acquired infections, CLABSI and CAUTI. And there has been intense focus on our journey to zero harm for our patients. And we have really worked hard on making sure that we are reducing hospital-acquired infections like CLABSI, CAUTI, and there were a lot of new tools that were built in Epic to nudge the providers that if a patient has a central line and it's not being used, they are able to discontinue that. Or if a patient has a Foley catheter, which is not needed, they are able to discontinue that. And some of those tools really helped our nursing and our physician teams. But when we started the work, before we made some changes, those tools were really inundating our clinical teams. So I think we have to constantly engage our clinical teams and make sure we are listening to their feedback so to make that change happen.
Thanks, Dr. Dang. I think your comments really speak to the idea that there is largely an understanding among the healthcare sector and the workforce that change needs to happen, but it's also important for leaders and the organization to really spell out the why and how that's going to affect their work. And I'm also glad you mentioned the acting on feedback component. I think so critical, particularly for clinicians to really see that their input matters with the different changes that are happening. Dr. James, can I turn it to you as well for a piece of advice here?
Sure. So I couldn't agree more with what Dr. Dang said. And I just want to follow up on something he spoke about with discontinuing central lines, Foley's, things like that. Like At Jefferson, we have those written protocols and policies for nurses to follow, but they're not built into the Epic, into the system to alert our nurses, hey, you need to take a look at this. I think that's very important and a way forward for us. So let's back it up to the beginning of our conversations. When you have nurses that are burnt out, they're not engaged, they're not going to make sure that those Foleys have, once, if there's no reason for a Foley to be in, a line to be in, they're not going to be engaged to really follow up on that and to pull those devices out. So it goes back to, well, AI can help us there, because if we have a non-engaged employee, then you can prompt them through the system to remove those things, which equals patient safety. So your current question, though, is I think it's important from at least a nursing leader standpoint that the nurse leaders feel comfortable implementing new technology change. There's change management, but then there's also implementing new technology. And going to the why is first and foremost. But the organization also needs to think strategically about how it's going to train its leaders to roll out this technology and how they're going to define the technology. So for instance, at Jefferson, we've used individuals from our population health university and from our own professional development team to put all of our nurse managers through a workshop on change management. It's only like a half-day workshop, but the things that we point out and the education that we provide has really helped our nurses begin thinking through those whys and thinking through those, well, I have to roll out this new initiative, whatever it is, next week. How am I methodically going to do that? So it's been a benefit. So I just think organizations need to think about the education up front and then roll that out to their leaders, and then their leaders can come through for them on the end.
Yeah, the leadership education component is so important as well. Dr. Barcuda, some parting words of advice from you here.
Thanks, Erica. So it is exciting phase in healthcare. I think the next step will be critical, how we can take the tools, and I love putting it in the why and not just jump to the what and the how. Between Dr. Dang and Dr. James and Dr. Henderson, I think that collective look would really be important, but we need to put the patient in the center of it. Privacy is always a concern. The way we're changing culture, the way we want our patient to get the best. And this is a reference to doctors, they do their best because they do their best, but we need to help them with that. And we can integrate it with the education and more to see how we can encounter the next phase. Exciting. Let's keep our eyes on the elements of protection of the patient and the profession.
Andreas, is there anything else you want to add here, feels important for our audience to know?
There was so many nuggets there, so thank you all for sharing. And I think just a final sort of comment on would be a little bit building on what Dr. Scott says, that there are so many other roles in healthcare beyond clinicians that will leverage all this technology. And I think to all of your point, it's going to be exciting to see this technology proliferate and be valuable to all these groups if we can implement it in a culturally sound way that takes all the local circumstances into consideration. I'm very excited to see all that happen with all of the new and ambitious leadership happening across the spectrum.
Yeah, absolutely. The culturally sound implementation is really, really key, as we learned. Well, that is all the time we have left on this one. I want to thank you all so much for your time and insights on a super relevant, super timely topic. And thank you to Corti as well for sponsoring today's session, and as well as to our attendees. We hope you all enjoy the rest of your day and look forward to seeing you at future Becker sessions.